Hello, everyone, and welcome to our module on the basal ganglia. So the basal ganglia are part of the central nervous system, and they are a collection of neuronal cell bodies. And the reason they're called the basal ganglia is because the word basal refers to the fact that they're found at the base of cortical structures, like the lobes of the brain. And then the word ganglia means a collection of neuronal cell bodies. And so what this collection of neurons does is it modifies voluntary movements. We'll talk about exactly how this occurs in this video, but the big picture idea is that the basal ganglia receive input from the cortex when the cortex wants to carry out a complex movement. And then the basal ganglia provide feedback to the cortex, telling it to either stimulate certain motor activities or inhibit other motor activities. And the combination of this feedback from the basal ganglia is how we carry out complex movements. So if you think about complex movements like shooting a basketball or playing a guitar, these things are more than simple on-off movements of muscles. You need to have some muscles activated, some muscles inhibited. And so the way we do these complex movements is by allowing the cortex to be influenced by the basal ganglia and also the cerebellum. So the basal ganglia consist of 5 structures, which I've listed on this slide for you here. Those 5 structures are the caudate nucleus, the putamen, globus pallidus, the substantia nigra, and the subthalamic nucleus. And you can see all 5 of these structures in this cross-section of the brain image that I placed on the slide here. So just to orient you, these are the 2 lateral ventricles that I'm marking with my pen here, and this is the 3rd ventricle right here. On either side of the lateral ventricles, that's where you can find the caudate nuclei. All the basal ganglia are paired structures, so you have one of the nuclei on the left and one on the right. Just below the caudate nucleus, you can see 3 structures. One is here, another is here, and another is here. The first one here is the putamen, and then these 2 here are the globus pallidus. It has an external segment and an internal segment. They each do different things, and we'll talk about that shortly. And then the substantia nigra is found down here. It's actually part of the midbrain in the brainstem. And then the subthalamic nucleus is shown right here. It's this very small structure right next to the 3rd ventricle. And here's another image just to make the anatomy of the basal ganglia very clear. So once again, we have the 2 lateral ventricles here, and we have the 3rd ventricle here. These are the caudate nuclei on either side of the lateral ventricle. This is the left and right thalamus here. Over here, we've got the putamen and the 2 pieces of the globus pallidus. Then we have the subthalamic nucleus right here, just below the thalamus. That's why it's called the subthalamic nucleus. And then finally, the substantia nigra is down here, which is basically at the level of the brainstem. So the major structures of the basal ganglia are those 5 nuclei we've talked about in the last 2 slides, but sometimes they're referred to by other terms, and this can be confusing. So let's talk about this now. So if you look at this cross-section of the brain on the slide here, this structure I'm circling with my pen consists of the putamen and also the globus pallidus. And it was thought to have the shape of a lens, so it was named the lentiform nucleus. This means the putamen and the globus pallidus together. They are close together in the brain, as you can see in this image here, and the word lentiform simply means lens shape. And then looking at this image once again, this is the putamen right here, and this is the caudate nucleus right here. And in between those 2 structures is the internal capsule. Those are these white matter fibers right here that I'm marking with my pen. And microscopically, there are little lines connecting the caudate and putamen called striations. And so together, these 2 basal ganglia nuclei are called the striatum. That means the putamen and the caudate. It's also called the striate nucleus. And as we'll see in just a minute, the striatum, meaning these 2 basal ganglia nuclei, are the major input from the cortex. When the cortex wants to carry out complex movements, it sends signals to the striatum. And as I said, they're divided by the internal capsule. There are small fibers that connect the 2 nuclei across the internal capsule. And so they're called the striatum, named for those visible striations. And so here's another cross-section of the brain. This one is an axial cross-section, and the brain looks like this in an axial cross-section. But once again, you can see a lot of these basal ganglia structures. This is the caudate nucleus here on either side of the lateral ventricles. This is the thalamus right here. I'm marking it on the left and the right on either side of the 3rd ventricle. And then this is the lentiform nucleus over here, which, as we just discussed, consists of the putamen and the globus pallidus. And you might be asked to identify some of these structures on an axial MRI, like the image I've shown on the left side of the screen here, and they're fairly easy to find. The caudate nucleus is going to be right here on either side of the lateral ventricles. This is going to be the thalamus right here, and the lentiform nuclei are going to be over here. The substantia nigra, as I've already mentioned, is actually a structure found in the brainstem. It's in the midbrain. I talk about it in the videos on the brainstem. It's located in this region of the midbrain in cross-section. And so on this axial MRI, which is at a lower level than the image we saw on the last slide, this is the midbrain right here, where you can find the substantia nigra. It has 2 separate parts to it that each carry out different functions. The substantia nigra pars compacta, or the SNC, is packed with dopaminergic neurons, meaning they secrete dopamine. And as we'll talk about later in this video, these neurons are what are lost in Parkinson's disease. The other region of the substantia nigra is the substantia nigra pars reticulata, or the SNR. It contains GABAergic neurons, which are neurons that release GABA, which is an inhibitory neurotransmitter. And these neurons inhibit the thalamus and inhibit motion, as we'll talk about in just a minute. Okay, so now that we understand all the different pieces of the basal ganglia, let's talk about movement execution. And by this, I mean the way that the basal ganglia helps our cortex to carry out complex movements or complex actions. So this can get very confusing, but try to keep the big picture in mind, which is what I've shown on the slide here. So the whole process begins when the premotor cortex decides to execute a complex movement or action. Premotor cortex will activate the basal ganglia. And then within the basal ganglia, there are two pathways of fibers. One is called the direct pathway, the other is the indirect pathway. The direct pathway can activate the primary motor cortex and create movement or action. In contrast, the indirect pathway inhibits the primary motor cortex and inhibits activity or movement. And so the combination of these effects is how we carry out complex movements and complex actions. So if you think about playing a guitar, you might want some motor fibers in your finger to contract. You might want others to not contract. And so what's going to happen is a complex set of pathways in the basal ganglia is going to be activated. Some of them are going to tell the motor cortex to activate certain pathways and to contract certain muscle fibers. Other muscle fibers are going to be told to relax. You're going to get this complex movement back through the cortex, assisted by the basal ganglia, that lets us do a complex maneuver like playing the guitar. Okay, so here's my own diagram of the basal ganglia connections, and this can be very confusing to learn, so I'm going to try to explain it to you in the simplest way possible. So the first thing you have to appreciate is that the cortex controls the neurons in the brainstem and the spinal cord that cause our muscles to contract or relax. And the thalamus wants to tell the cortex to cause muscle activity. In other words, it wants to send positive signals to the cortex, telling the cortex to activate the brainstem and spinal cord so that we get muscle activity. What the basal ganglia does basically is it holds back the thalamus. It inhibits it unless it wants it to be active. So it's choosing to either allow the thalamus to activate the cortex like it wants to, or to inhibit the thalamus so you get less movement. The way the thalamus is controlled is by two structures, the globus pallidus internus, which is part of the globus pallidus, and the substantia nigra pars reticulata, which is part of the substantia nigra. Both of these components of the basal ganglia can release GABA, which is an inhibitory neurotransmitter, onto the thalamus to tell it to stop signaling the cortex, and that will inhibit movement. And then these other structures in the basal ganglia, like the subthalamic nucleus, the globus pallidus externus, the pars compacta of the substantia nigra, and the striatum, they all interact to either allow the globus pallidus internus and the pars reticulata to inhibit the thalamus or to stop it from inhibiting the thalamus. So I know that may be confusing. I'll go over it more in just a second, but eventually, hopefully this picture will make sense to you as to how the basal ganglia are influencing the cortex to create complex movements. So let's start by talking about how all these elements work together to stimulate movement via the direct pathway. Remember what I said before, the direct pathway is the pathway within the basal ganglia that stimulates movement. So the whole process is going to begin with the cortex, which will tell the basal ganglia that it wants to carry out a complex movement. The cortex will release glutamate, which is an activating neurotransmitter, onto the striatum and also onto the substantia nigra. Once the striatum is activated, it is going to release GABA onto the globus pallidus internus and onto the substantia nigra pars reticulata. That is going to shut down these regions of the basal ganglia. And remember, those two regions, as we just talked about in the last slide, they normally inhibit the thalamus. So by shutting these two regions down, you will lose the inhibition of the thalamus, and the thalamus will do what it wants to do and activate the cortex, and that will in turn activate the brainstem and spinal cord, and that's how you get movement via the direct pathway. Now, you should also be aware that a somewhat special element of this that can be confusing is that the cortex is also going to tell the pars compacta to release dopamine onto the striatum and activate D1 receptors. This is going to amplify this whole process. So the big picture of what's going on is the striatum is shutting down these structures here, but this whole thing is being amplified by the pars compacta, which is releasing dopamine onto D1 receptors in the striatum to make this process work even more. And so I've summarized these points on the slide here. So the whole process of the direct pathway begins by the cortex sending signals to the striatum via glutamate, which is an excitatory input. The striatum then is going to inhibit the globus pallidus internus and the substantia nigra pars reticulata. It's going to use GABA, which is an inhibitory neurotransmitter, to do this. That in turn is going to cause the globus pallidus internus and the substantia nigra pars reticulata to stop inhibiting the thalamus. This is going to free up the thalamus to let it do what it wants to do and activate the cortex, and that's what's going to lead to movement via the direct pathway. And then on the side, you have dopamine amplifying this pathway via D1 receptors in the striatum. Basically, the substantia nigra pars compacta, which is that region of the substantia nigra that's packed with dopamine neurons, it releases dopamine onto the striatum and primes the striatum for cortical stimulation. So this helps to amplify the effects of the direct pathway. Okay, so that's how the direct pathway works, which, believe it or not, is the easier of the two pathways involving the basal ganglia to understand. Now let's talk about the indirect pathway, which I've depicted on this slide here. So once again, the whole process starts in the cortex, which wants to carry out a complex movement. And when the indirect pathway is involved, it means that the complex movement requires inhibition of motor activity. So the cortex is once again going to send signals to the striatum using glutamate as a neurotransmitter. But when the indirect pathway is activated, what the striatum does is it releases GABA onto the globus pallidus externus. And remember, GABA is inhibitory. So what this is going to do is inhibit the globus pallidus externus. Now here's the confusing part. Normally, the globus pallidus externus is releasing GABA onto the subthalamic nucleus. But when you inhibit the GP externus, you stop releasing GABA, and that frees the subthalamic nucleus to do what it wants. And what it wants to do is activate the globus pallidus internus, which, if you recall, is a part of the basal ganglia that inhibits the thalamus. So this whole process is going to increase the activity of the globus pallidus internus, which is going to further inhibit the thalamus using GABA, and that's going to lead to inhibition of the motor cortex and less movement. And that's how the indirect pathway inhibits movement. Now, one side element here that I want to point out, I told you that in the direct pathway, the substantia nigra pars compacta releases dopamine onto D1 receptors in the striatum to amplify the direct pathway. Well, you don't want the direct pathway and the indirect pathway occurring at the same time. So just like dopamine activates D1 receptors to amplify the direct pathway, it also can bind to D2 receptors to shut this whole pathway down. So the key point here is that dopamine from the pars compacta has a dual purpose. It increases the activity of the striatum through D1 receptors, and it decreases the indirect pathway activity using D2 receptors found in the striatum. And so here's a summary of the key takeaway points from the indirect pathway. It begins with cortical excitation of the striatum via glutamate, and then the striatum is going to inhibit the globus pallidus externus. As a result, the globus pallidus externus will stop inhibiting the subthalamic nucleus, and the subthalamic nucleus will be free to do what it wants to do, which is to activate the GP internus and also the pars reticulata, and then those two structures will do what they want to do, which is to inhibit the thalamus, and as a result, you'll get an inhibition of these signals going to the cortex and movement inhibition generally. And then once again, this is not part of the indirect pathway, but something to be aware of is that dopamine inhibits this pathway by binding to D2 receptors in the striatum. And so that's a nice segue into talking about dopamine. Dopamine is a key neurotransmitter for the basal ganglia. It can turn on the direct pathway and amplify it, and that leads to movement. It also turns off the indirect pathway, which in turn leads to movement. So the bottom line is that dopamine shuts down the indirect pathway, activates the direct pathway, and both of these effects together lead to the generation of movement. What this means is if you lose dopamine, as happens in Parkinson's disease, which we'll talk about shortly, the indirect pathway is overactive. Make sure you understand this. Without dopamine, you don't get the amplification of the direct pathway and you don't get the inhibition of the indirect pathway. And as a result, you get overactivity of the indirect pathway. And this leads to loss of movement, which is a key feature of Parkinson's disease. And to make all these things clear, I've summarized this in the table at the bottom of the slide here. High dopamine from the substantia nigra activates the direct pathway via D1 receptors. It suppresses the indirect pathway via D2. And the net effect is to promote movement. The opposite happens when dopamine levels are low. You get suppression of movement, and that's what happens in Parkinson's disease. So shown on this slide are some of the classic disorders involving the basal ganglia. The two big ones are Parkinson's and Huntington's disease. Others are hemibolism and Wilson's disease, and they all involve disordered movement. In this video, I'll just talk about the first two because these are sort of classic examples of overactivity or underactivity of the basal ganglia. So in Parkinson's disease, you lose dopaminergic neurons from the substantia nigra pars compacta. Remember, that's the part of the midbrain that we talked about earlier in this video. And as we've already discussed, when you lose dopamine in the basal ganglia, you get underactivation of the direct pathway because you're not stimulating the striatum via those D1 receptors. And the indirect pathway becomes overactivated because you're not inhibiting it with dopamine on D2 receptors in the striatum. So the net result is that when you lose dopaminergic neurons, you get indirect pathway dominance. This means the thalamus is going to underactivate the cortex, and as a result, you will have hypokinesia or difficulty initiating and carrying out movements. And so shown on this slide are some of the clinical features of Parkinson's disease, which I talk about in detail in the video on Parkinson's. But what I want to point out to you here is that you can tie many of these clinical features, these symptoms of Parkinson's disease, back to the basal ganglia. So remember that Parkinson's disease is a hypokinetic disorder where, in general, patients have trouble initiating and carrying out complex movements. So some of the symptoms you can see are, first of all, rigidity around joints because it's difficult to move around a joint. Patients also have slow movements in general. The slow movements make it difficult to walk, so they have a slow shuffling gait and they're vulnerable to falls from postural instability. And then lastly, a classic feature of Parkinson's disease is a tremor at rest. This is a strange symptom because it's excessive movement, but it's related to a complex origin that's got to do with losing dopamine in the substantia nigra. And I talk about it in more detail in the Parkinson's video. And then there are surgical therapies for Parkinson's disease, which I won't talk about in detail here, but I just want to point out to you that they involve elements of the basal ganglia that are part of the indirect pathway. Remember, the indirect pathway is overactive in Parkinson's, and you can shut it down surgically. Basically, what these surgeries aim to do is suppress the overactive inhibition of the thalamus, either through ablation, which is destroying basal ganglia tissue, or by implanting devices called deep brain stimulators that stimulate elements of the basal ganglia, and they paradoxically, over time, suppress those elements. This is a functional inhibition without destroying tissue through surgery. So let's look at this drawing at the bottom of the slide here. This is the indirect pathway. It's overactive in Parkinson's disease. So if you want to shut it down, some of the things you could do are, first of all, you could inhibit the globus pallidus internus. That's one of the surgical treatments for Parkinson's disease. If you do that, then it will stop inhibiting the thalamus and you'll get some more movement. You also could inhibit the subthalamic nucleus. Remember, this normally activates the GP internus. So by destroying or inhibiting this, you stop activating the GP internus and you get less inhibition of the thalamus. And then there are also ways to directly target thalamic nuclei so that you improve their signals going to the cortex. Hopefully, much of this makes sense to you now that you understand the indirect pathway is overactive in Parkinson's disease, and the surgery is designed to stop that overactive inhibition. Okay, so Parkinson's disease is the classic example of the indirect pathway being overactive, so you get decreased movement. In contrast, Huntington's disease is the classic example of the direct pathway being overactive, so you get too much movement. So the cause of Huntington's disease is loss of striatum neurons. You can actually see on imaging in patients with Huntington's disease atrophy of the caudate and the putamen in images of the brain. And remember, those neurons in the striatum release GABA and inhibit other structures, so you're going to lose those inhibitory actions of the striatum. And so initially in patients with Huntington's disease, what happens is the indirect pathway is lost. So you get a loss of movement suppression, and as a result, you get overactivity of the direct pathway and hyperkinesia. I talk about the clinical features of Huntington's disease in detail in the video on movement disorders, but I'll just summarize some of the clinical features here and talk about how they tie back to the basal ganglia. So Huntington's disease is a genetic disorder, so it runs in families, and the typical age of onset is relatively young, usually in the 30s or 40s. And one of the hallmark features of Huntington's disease is chorea, which is a type of involuntary movement. And so this is like the opposite of Parkinson's disease, where Parkinson's patients can't initiate movements. In Huntington's disease, patients have excessive involuntary movements. This is called chorea, and it's related to damage to the basal ganglia. Other symptoms of Huntington's disease include cognitive decline and psychiatric symptoms, and all of these I talk about in the video on movement disorders. And so here's a summary slide to help you keep these two classic basal ganglia disorders straight. So remember, Parkinson's is the classic example of a hypokinetic basal ganglia disorder. In this disorder, the globus pallidus internus is excessively inhibiting the thalamus, and so it's not activating the cortex, and that leads to hypokinesis. In contrast, Huntington's disease is the classic example of a hyperkinetic disorder. In this disorder, the GP internus is not inhibiting the thalamus, so it's excessively activating the cortex, and that's what leads to hyperkinesis and symptoms like chorea that you see in Huntington's disease. And so I'll finish with this one slide, which shows all the connections in the basal ganglia. And on this slide, I've sort of indicated the areas that are affected in various diseases. Super high yield to know that Parkinson's disease affects the substantia nigra, and it eliminates dopaminergic neurons in the pars compacta. Also very high yield to know that Huntington's disease is associated with atrophy of the caudate and the putamen in the striatum. And then hemiballism, which I talk about in another video, affects the subthalamic nucleus, and Wilson's disease, which is a copper disorder that can affect the brain. That can affect the globus pallidus. It can also affect the striatum as well. And that concludes our module on the basal ganglia.